Hello and welcome. If you're prepping for your pediatrics exams, you absolutely know the feeling. Neurology is just a massive topic. So today we're going to build a really clear, high-yield framework to help you connect the dots between some of its most important conditions.
It's such a common feeling, isn't it? You've got pages and pages of notes on seizures, cerebral palsy, all the muscular dystrophies, and trying to connect them all, especially when you're under exam pressure, it can feel next to impossible. So that's exactly what we're going to do. We're going to build that framework. In this review, we'll zero in on the must-know concepts that always show up on exams, and most importantly, we'll connect those dots between the brain, the nerves, and the muscles.
All right, let's start at the command center, the central nervous system, with 4 conditions that are just fundamental to pediatric neurology.
First up, seizures. Now, the key word you've got to remember here is paroxysmal. It really just means a sudden, intense burst of activity. So you can think of it like an uncontrolled electrical storm in the brain that then shows up physically. This core definition is your perfect starting point.
Now, for a super high-yield emergency protocol, managing status epilepticus. The whole principle here is a clear, step-by-step escalation. You always start with the ABCs: airway, breathing, circulation. Stabilize the patient first. Then you move to your first-line drug, a benzodiazepine, like lorazepam. If the seizure doesn't stop, you don't panic. You just systematically escalate to your second and third-line agents. This structured approach is absolutely critical.
Let's move on to our next core topic, cerebral palsy. Okay, the most crucial part of this definition is the term non-progressive. What this means is that the initial brain injury itself doesn't get worse over time, even though the physical signs might change as a child grows. This is what really separates it from neurodegenerative diseases.
This table is fantastic for breaking down the main types of CP. For your exams, you really want to focus on the causes. Notice that classic association, spastic quadriplegia, which is the most severe form, is often linked to perinatal asphyxia. Meanwhile, spastic diplegia is the classic hallmark of prematurity. Remembering these associations is key for those clinical vignettes.
Next up, meningitis. It's an inflammation of the meninges, but in pediatrics, the real diagnostic challenge is in the little ones, the infants, where the signs can be incredibly subtle.
And that's exactly why this slide is so important. In an infant, you're just not going to see that classic neck stiffness or photophobia. Instead, what you're looking for are these non-specific but critical red flags: a shrill, high-pitched cry, being profoundly irritable, and especially a tense or bulging fontanelle. Those things should make you immediately think of meningitis.
So things like meningitis, tumors, or even trauma can all lead to raised intracranial pressure. And this is a true neurologic emergency. Why? Because as pressure builds up inside the fixed box of the skull, it can start to compress and damage really vital brain structures.
Managing raised ICP is really all about creating space and reducing that pressure. You can start with simple things, like just elevating the head of the bed. Then you can use controlled hyperventilation, which causes vasoconstriction and reduces the amount of blood in the brain. And of course, osmotic agents like mannitol work by literally pulling fluid out of the brain tissue. These 4 principles are really the cornerstone of management.
Okay, so we've covered the central command. Now let's move out peripherally and take a look at the pathway from the spinal cord all the way down to the muscles.
The single most common way a neuromuscular disorder presents in a child is hypotonia, or what we often call a floppy infant. The absolute crucial first step in your evaluation is figuring out if the cause is central, up in the brain, or peripheral, meaning it's located somewhere in the motor unit itself.
Speaking of peripheral causes, let's talk about a classic myopathy, Duchenne muscular dystrophy. So remember, this is an X-linked recessive condition, so you're mainly going to see it in boys. The problem is the lack of the protein dystrophin, which basically acts like a shock absorber for muscle cells. Without it, the muscles just progressively break down. And this picture shows the clinical result perfectly. This is the Gower sign, and it's practically a dead giveaway for DMD. You see how the child has to use his hands to push off his own legs just to stand up? That's because his proximal hip and thigh muscles are just too weak to do the job by themselves. If you see this in an exam question, your brain should immediately scream Duchenne's.
Now, let's contrast that muscle problem with a nerve problem, spinal muscular atrophy. Here, the issue isn't actually in the muscle itself. It's in the motor neurons in the anterior horn of the spinal cord. Those nerve cells are degenerating, so the signal to the muscle gets lost, and that leads to weakness and profound atrophy.
Okay, let's take a minute to clear up some common points of confusion. I promise you, getting these differentiations right is absolutely critical for your exams.
Let's go back to our floppy infant. How in the world do we tell if the problem is central or peripheral? Well, you look at the deep tendon reflexes. In central hypotonia, the reflexes are often totally normal or even brisk. But in peripheral hypotonia, where the motor unit itself is affected, those reflexes will be depressed or completely absent. That is your single most important clinical sign.
And this ties directly into another fundamental concept: UMN versus LMN lesions. Cerebral palsy is a classic example of an upper motor neuron problem, and that leads to spasticity and hyperreflexia. In contrast, spinal muscular atrophy is a classic lower motor neuron problem, which results in flaccidity, hyporeflexia, and often those little muscle twitches called fasciculations. Understanding this difference is just essential.
And here are a few final rapid-fire clarifications. A simple febrile seizure is not epilepsy. The key difference is that epilepsy is defined by unprovoked seizures. And finally, please don't confuse myasthenia gravis with SMA. Myasthenia is all about fatigable weakness at the neuromuscular junction. The muscle gets tired with use. SMA is a constant weakness from a problem back on the anterior horn cell. Totally different locations, totally different clinical pictures.
All right, we have covered a lot of ground, so let's boil it all down to the absolute must-remember takeaways for your exam. If you remember nothing else from this, remember this slide.
Here it is. For status epilepticus, it's ABCs, then lorazepam. For cerebral palsy, remember, non-progressive and spastic quadriplegia is the most common type after asphyxia. For an infant with suspected meningitis, your big red flags are a bulging fontanelle and irritability. For Duchenne's, think X-linked, progressive weakness, and that classic Gower sign. And finally, for hypotonia, use the deep tendon reflexes to tell the story. Brisk for central, absent for peripheral.
So there you have it. That's your framework. The key isn't just memorizing the facts, it's about recognizing the patterns. So the next time you're faced with a neurological case, ask yourself, is this problem central or peripheral? Is it an upper or a lower motor neuron sign? Answering those questions, well, that's the first step from studying medicine to actually practicing it. Good luck with your revision.